Hello, and welcome to the RSNA Radiographics Podcast. My name is Clint Sliger, and I am an emergency and trauma radiologist at the University of Maryland Medical Center in the R. Adams Cowley Shock Trauma Center. During today's podcast, I will discuss the article Imaging of Cardiac and Non-Thoracic Vascular Trauma, which was co-authored by Doctors Costabader, Behestian, Fleiter, Judy, Kundi, Smith, and myself. This article was published in the February 2026 edition of Radiographics. Now, cardiac and major thoracic vascular injuries are uncommonly encountered in most radiology practices, primarily because of their high pre-hospital mortality. For example, while blunt cardiac injuries have an incidence of 3.3% among the patients listed in the National Trauma Data Bank, autopsy studies have suggested that they are more common and found in 32% of fatalities that result from blunt thoracic trauma. Penetrating cardiac injuries are also uncommon in clinical practice due primarily to high pre-hospital mortality rates that have been reported to range from 50% to 75%. And even among those patients who reach the hospital alive, there is still an 80% mortality rate. And not to be forgotten, non-aortic major thoracic vascular trauma may also be devastating. For example, superior vena cava and suprahepatic inferior vena cava injuries have mortality rates that approach 100%, which leads them to be rare in most clinical practices. Now, it's important, while many of these injuries are rapidly fatal, not all of them are. So, as radiologists involved in trauma care, we will likely see one or more of them over the course of our careers. Therefore, it is important that we remember to actually think about these injuries, but then also recognize what they look like and be familiar with the various imaging findings. These injuries may result from either blunt or penetrating mechanisms, with the resulting spectrum of injuries ranging from clinically insignificant to rapidly fatal. Blunt traumatic injuries are typically due to high energy mechanism, such as motor vehicle collisions, motor vehicles striking a pedestrian, and fall from a great height. Applying mainly to injury to the heart, potential injury mechanisms include precordial impact, compression of the heart between the sternum, ribs, and thoracic spine, lacerations caused by rib or sternal fracture fragments, and general indirect forces transmitted from the abdomen through the diaphragm. Penetrating injuries usually occur due to gunshot wounds or stab wounds. Injuries to the anatomic region known as the cardiac box should raise particular clinical concern for a cardiac or major vascular injury. To those unfamiliar with the term, the cardiac box is the space bordered by the clavicles and sternal notch superiorly, the mid-clavicular lines laterally, and the costal margins inferiorly, with the borders of the box projected from the anterior through the body to the back. Penetrating trauma is more likely than blunt trauma to cause cardiac lacerations, aortic arch branch injuries, caval injuries, and injuries to the brachiocephalic and subclavian veins. Yet it's important to note that blunt trauma may result in injury to any one of these structures. Regardless of the injury mechanism, the right ventricle is the most commonly injured cardiac structure due to its anterior location. So, when suspecting a cardiac injury, this area should be subject of special attention. Before moving forward, I want to discuss some CT protocol considerations. Many institutions utilize a single phase scan of the chest regardless of injury mechanism. In contrast, my co-authors and I at the University of Maryland used two different CT protocols to scan when there is blunt trauma in comparison to penetrating trauma. Specific details of the protocols are included in a table in the article, but I'd like to briefly discuss some of the reasoning behind our protocols. We use a dual energy arterial phase CTA in patients with blunt chest trauma. Now, patients with penetrating chest trauma will undergo a biphasic scan with an initial high pitch, fast scan in the arterial phase, followed by a dual energy scan in the portal venous phase. Regardless of the protocol, scanning can include the abdomen and the pelvis. In the setting of penetrating trauma, we use a biphasic protocol because, in our experience, it facilitates diagnosis of some injuries that are more commonly encountered in the setting of penetrating trauma than in blunt trauma. First, the initial high pitched scan limits artifact due to cardiac motion and breathing, which will facilitate diagnosis of cardiac, coronary artery, and ascending aortic injuries. Second, the subsequent portal venous phase images may improve recognition of slow, active bleeding, venous injuries, and myocardial perfusion defects. We also stress that the use of dual energy acquisitions is important for those who have the capability to do so. We use this primarily for problem solving purposes. For example, low KEV virtual monogenic images and iodine mapping make possible by dual energy scanning can be used to identify subtle extravasated IV contrast that is the result of active bleeding. Alternatively, virtual non-contrast images may be used to differentiate active bleeding from non-metallic high attenuation foreign bodies such as surgical pledgets and bone fragments. Now that I've discussed briefly some imaging protocol factors, I'll move on to what these injuries look like on CT. To recognize this injury, it's unfortunate that there is a broad spectrum of possible imaging findings that must be recognized. Fortunately, whether it be blunt or penetrating trauma, these injuries share many imaging findings in common. So we can apply them to both penetrating and blunt injuries. Now, first focusing on cardiac and pericardial injuries, we may see myocardial contusions, myocardial and pericardial lacerations, cardiac or pericardial rupture with direct visualization of a free edge or edges in the defect, cardiac pseudoaneurysm, and frank active bleeding. Rather than going into each one of these injury manifestations in great detail, I want to highlight some important points to remember. First, myocardial contusions typically appear as areas of diminished myocardial enhancement that may be more conspicuous in the portal venous phase. Importantly, a myocardial laceration may also appear as an area of diminished myocardial enhancement rather than a focal myocardial defect. As a result, frequently we cannot differentiate between the two. Pericardial and cardiac injuries may be associated with either pneumopericardium or hemopericardium, which makes them useful secondary signs of an injury. However, it is important to recognize that a lack of pneumo or hemopericardium does not exclude injury to either the pericardium or heart. One scenario in which there is a cardiac injury without hemopericardium is when there is also a pericardial rupture that allows blood to decompress into either the pleural space or diaphragm. As a result, when there are signs of local trauma in the region of the heart, the presence of a hemothorax or diaphragm injury should prompt extra scrutinization of the heart, especially in the setting of penetrating trauma. Pericardial ruptures may rarely lead to herniation of the heart through the defect if the defect is large enough, usually over 8 to 12 centimeters. Herniation of the heart through a ruptured pericardium can be very subtle and difficult to appreciate. Rupture may be suspected if the heart deviates from its normal location, even if the pericardial defect is not visualized. It is important to recognize cardiac herniation because it may lead to cardiac torsion that occludes the great vessels and subsequently results in cardiac strangulation. Moving away from the heart, I will discuss non-aortic vascular injuries, which can involve the coronary arteries, pulmonary vessels, large central systemic veins, and aortic arch branches, all of which may exhibit various types of injury. Specific injury findings include intramural hematoma, intimal flap, intraluminal thrombus, pseudoaneurysm, arteriovenous fistula, occlusion, and active bleeding. An important but nonspecific secondary sign of major vascular injury is a perivascular hematoma. Earlier, I mentioned that injuries to the great vessels may be devastating. However, other vascular injuries may also be devastating despite their being smaller size. Specifically, I want to mention the intercostal and internal mammary arteries. While they are small, they are high flow vessels with rich collaterals that may promote active bleeding. While many of these vascular injuries do not warrant direct intervention, it is still important to identify them whenever possible, since they can lead to clinically significant bleeding either immediately or in a delayed manner. I want to make additional mention about the internal mammary arteries. With an incidence of between 10 and 30% of all thoracic injuries, usually due to penetrating trauma, internal mammary arteries are not rare. Nonetheless, in my experience, they are frequently overlooked. In the patient in the history of penetrating trauma to the cardiac box or blunt trauma, an internal mammary artery injury should be considered when there is hemomediastinum, hemothorax, or subpleural chest wall hematoma, especially in the presence of costal cartilage and sternal fractures. In penetrating trauma, it is important to identify the projectile or other penetrating object, which may serve as a sign of a major vascular injury when in very close proximity to the vessel in question. Importantly, when beam hardening from a metallic foreign body obscures the adjacent suspect vessel, an injury cannot be excluded by CTA and either DSA or exploration of the area will be needed to exclude or diagnose an injury. An additional point about penetrating trauma focuses on gunshot wounds. Gunshot wounds and other projectile related injuries may result in either an intracardiac cavitary or intravascular foreign body, which can then embolize distally and cause end organ ischemia. Because of this risk of embolization, the projectile is frequently extracted. With this in mind, it is incumbent upon the radiologist to accurately identify all intracavitary or intraluminal projectile fragments so they may be addressed accordingly. Cardiac and non aortic cardiac injuries are generally uncommon in routine practice, but may be potentially devastating, life threatening injuries. While some who survive to reach the hospital may go to surgery rather than CT, many patients will still be scanned. On CT, these injuries are frequently very subtle. It is therefore incumbent upon radiologists involved with trauma care to be familiar with the various imaging findings of these injuries, as well as of those times when we should suspect an injury without direct visualization of it. Because most of these injuries are rare, it is important to maintain an index of suspicion whenever reviewing the diagnostic images of patients with severe acute thoracic trauma. This concludes my discussion, but before going on, I ask you to please rate and review this podcast, as well as to subscribe to future podcasts. By doing so, you will help maintain the quality of Radiographics podcast offer and expand their audiences. Also, please visit the Radiographics website to read this article and gain a more in depth understanding of this topic. While there, I also encourage you to review the other outstanding articles that are currently available. Before leaving, I want to thank my co authors, Dr. Kostenbader and Behestian, for their outstanding work on this article when they were residents. I also want to thank Dr. Weaver and RSNA for their invitation to participate in this podcast. Finally, I thank you, the listeners, for joining me, and I appreciate your time.